Hi, good evening. From Jab we met to the Met in Katrina and Vicky Kaushal, and I see all the guys are totally burnt, ashes, ashes, ashes. So here I am talking about the real men. Just a compliment to the two speakers. Very well done. I just have a patient to share, just to reiterate the same story. So basically, a 60-year-old Asian female, non-smoker, presents with persistent cough, found to have a left lung mass. Chest CT also confirms that, adenocarcinoma lung, metastatic disease on abdominal CT scan, and brain MRI also shows multiple metastases. Chest X-ray, again here, you can see the lesion, and chest CT, you can see the lesion as well. So, question, how do we do the testing? Do we do our oncogenic drivers? She's a non-smoker and with lung cancer, advanced lung cancer. Do you do the NGS or do you do your oncogenic drivers up front? Do you do it at progression? And how do you treat your patients? We're just trying to drive home the message about how to choose therapy in first line setting. So yes, would you start the patient on therapy right away? Would you give chemotherapy? Would you add the immune checkpoint inhibitor in the first go after the initial driver mutation testing? What all do you test for? So a lot of us are testing EGFR ALK-ROS. Some of us are testing EGFR ALK-ROS BRAF and PD-L1, and some of us are doing the entire NGS panel. Which category do you fall in, and how do you decide your patients? So just mentioning my style here, I actually, whatever the patient comes in with at the time of initial review or evaluation, immediately preserve the tissue, send in for comprehensive genomic profiling, pretty much to conserve tissue and not have to go back for retesting. This is the classic prototype that you can get. This is an Asian female non-smoker. Better to get your answer regarding driver mutation right up front, because we know immune checkpoint inhibitors don't work that well in driver mutation positive patients. So I don't limit myself to EGFR, ALK-ROS, I go beyond. And that testing needs to happen upfront, because if you don't do it upfront, you'll run out of tissue. And that's when you'll not be able to catch a lot of the stuff that you should be catching. So does broad panel molecular testing happen at your treatment center? And do you want to get tissue, or are you okay with liquid biopsies? And to that, I would say always attempt to get enough tissue, because PD-L1 needs to be done as well. And if you're suspecting driver mutation positive patient and you don't have tissue, PD-L1 to me becomes secondary, because if this is a classic prototype of a driver mutation positive patient, then I'm going to go after the driver. And in that situation, even if the PD-L1 comes in very high, I don't believe that and don't act on that. So broad panel molecular testing for this patient reveals a MET exon 14 non-small cell lung cancer, adenocarcinoma, and the PD-L1 expression is above 50%. Based on the current practice, do you think the diagnosis is correct? And do you think the treatment should be a MET inhibitor, or do you think the treatment should be other systemic treatments like chemotherapy plus immunotherapy, or immunotherapy alone? So if this patient, so this patient goes on a MET inhibitor. Now, which MET inhibitor would you prefer? You just heard Dr. Ullas Patra with his great speech, and which MET inhibitor would we choose out of these four that are enlisted here? And from the very nice diagram that he showed, it was, of course, the response rates were highest with capmatinib. And this is a slide that just reiterates the same question, the options that we have. And today we have capmatinib with the highest response. And the type 2 TKIs, because we just saw cabozantinib launched, I also want to put in a word here that these are actually not specific. And so you need to look at specific wherein MET exon 14 activity is going to be there. And these are the 4 that you are going to juggle from. And crizotinib at this juncture falls short significantly of the response, expected response from the MET inhibitor vis-a-vis capmatinib. And you can easily see it in this bar graph that capmatinib's response rate is in the range of 64%, which was described by Ullas just a few minutes ago. And when you look at the outcomes in the BERT study, you can easily see here that the first line utilization of capmatinib gave the highest response rate of 67.9%, versus if you had second line, it was 51.6%, and third line, 40%. So the responses do go down. The time is to attack in first line, and updated efficacy is also shown here, where the duration of responses are obviously the longest in patients who were given the drug first line versus pre-treated patients, where you still do get benefit, and the benefits are significant, but not as much as you would expect if you were giving it first line. And the median overall survival that we have here, again, in the treatment naive group was significant at 20.8 months versus 13.6 months in pre-treated patients, as seen in cohort 4. Again, response rates more prominent, and in the vision study also we have tepotinib, and so Ullas discussed about this as well, but the response rates are just lesser than what we have seen for capmatinib. So till now, that's our drug to go. And intracranial efficacy in this slide shows objective response rates that are significant for 47.8% of patients and disease control rate of 73.9. Just underlining that point, because my patient has brain metastasis, and whether or not this would be a patient to benefit from capmatinib. So you just saw significant responses even in the brain. So just talking about what are the barriers to current testing processes in non-small cell lung cancer patients in your practice. A lot of us are not aware that we need to do adequate biomarker testing right in the first line. A lot of us are also implementing Keynote 189 in driver mutation negative patients, but not looking enough for the driver mutation, even in classic prototype, believing PD-L1 that is high, PD-L1 percentage that is high. And let's say we tested for 4 driver mutations and those driver mutations came back negative. Even in a classic prototype, if the PD-L1 is high, I've done this earlier, wherein the initial testing did not show anything, PD-L1 high, gave the Keynote 189 regimen only to retest later and find out that the patient had something. And that's why failed the Keynote 189 sooner than other patients. One of the classic things that I have...
sorry to interrupt, ma'am. We've run out of time. So if you could conclude.
Okay. Classic driver mutations that are seen, that are missed out, are one of them is MET exon 14. And one of the reasons is the testing method should be perfected. RNA-based testing methods are considered to be even more specific. Liquid biopsy-based testing has been shown to pick up MET exon 14, and that is also something that can be utilized with classic responses here in this study with 81% response. Drugs are very well tolerated, as was just shown. So my patient goes on to receive capmatinib 400 BD and has minimal side effect with minimal rash, fatigue, peripheral edema, and continued the treatment for over 6 months with significant response and benefit. Would you have considered a MET inhibitor versus chemo IO for this patient. And as shown by Dr. Ullas Batra, the responses with chemotherapy, immunotherapy, combination, crizotinib, all of those are inferior to what we see with capmatinib in this patient population. And so one should wait for NGS test results before implementation of immune checkpoint inhibitors in a classic prototype of driver mutation positive patient, and ignore the PD-L1 for these patients. That's what I would appeal, and do the broad panel testing upfront if at all possible. With that, thank you for the opportunity. I hope you found my case interesting. But the most interesting discussion is the Jab We Met discussion. Thank you.